90s that if you can only use that drug 5 days in a row. It can't be used every day, and you can't go beyond 5 days. But that's the one really potent non-opioid drug we have. Okay? It can be used subcutaneously. Orals are problematic because it's got such problems with GI bleeding, but injectable, yes. In my way of thinking, these patients that fail those standard treatments, or even some that don't, ketorolac injections are terrific. And I want to make a quick point about anti-inflammatory agents. If you don't take anything away from me today, take this one home. We never realized it, but the vast majority of anti-inflammatory agents do not cross the blood-brain barrier and get into the spinal fluid in a high enough concentration to be effective. That's why for years I kept wondering why Motrin and Naproxen and Celebrex didn't work in most of my patients. And that's because those drugs don't cross the blood-brain barrier very well. We have very few anti-inflammatory agents that will cross that barrier in a high enough concentration to be effective. Ketorolac does, and the old drug indomethacin does, and I'm not sure we have another one. Okay? So what I'm getting at is that anti-inflammatory agents have been a little disappointing, but what the heck? Some of your anti-seizure agents, as you know, like gabapentin, cross very well, and so we get a good effect. But these are some of the things that are used. Another thing that I want to pass along today is this. The whole world is frightened about corticosteroids, and they should be. And guess what? Very few of them cross the blood-brain barrier in a high enough concentration to be effective. Only two do, methylprednisolone and dexamethasone. That's why you can take somebody with RSD or arachnoiditis, Lyme disease, what have you. You can give them all the prednisone in the world, it's not going to help their pain much because it doesn't cross the blood-brain barrier. Even compounded hydrocortisone doesn't cross very well. So low-dose intermittent corticosteroids 2 or 3 times a week does work. Here's another thing that I want to pass along to you today. This idea that we start drugs on people and have them take them every day for pain is probably an erroneous concept. In other words, pain is intermittent. Even those people who have centralized intractable pain don't need to take anything every day. Long-acting opioids are almost a thing of the past, should be, because people can be treated, they can treat themselves intermittently. Hardly any of these agents need to be, and in my opinion, shouldn't be used on a daily basis. They almost can be used intermittently as you need them. So another concept in pharmacologic treatment and keeping people within the standard guidelines is you don't have to give somebody low-dose naltrexone every day. You can if you want to. Same way with oxytocin, or same way with ketorolac. So keep in mind that I'd like for you to leave here thinking for a moment to do what the cardiologists have started doing. You may not need to take these drugs every day. Only take them when you need them. Okay? So this idea that and all of us have been doing this for years, somehow we've kind of gotten into this habit of, take your drugs 4 times a day, whether it's gabapentin or whether it's a steroid, and that's probably erroneous. You give them a few hours of a holiday. To keep people safe, you want that serum to clear the drug for a few hours a day if you can possibly do it. Don't leave a drug in the serum any more than you have to do so to keep down side effects, keep them non-tolerant, and get a better effect over the long term. Now, the microglial suppressors. These are the drugs that have been shown, mainly in animal studies, but now a lot of clinical reports, that will suppress the microglial cells. And you want to take a look at that list, see which ones you're familiar with, and use it. It's amazing that we were confused about this because these drugs come from different pharmacologic classes, and we always like to think of drugs in a class. But these all have been shown to suppress the microglial cell. For example, you can increase your effectiveness in your whatever pain regimen you like to use by giving somebody metformin at bedtime. So these are the kind of things you have available today that will enhance just about any treatment regimen. Now, here is the profile of people who are going to fail that three-step ladder. And these are tragic cases. Make no mistake about this. If you have really been given standard treatment and you don't make it, you've got a serious, serious problem. And you've got a lot of people today and regulatory agencies, even in the professions, that want to deny these people exist. But they exist. And here's their profile. First thing is their pain is centralized. And how do you know pain is centralized? Well, that's easy. They're going to tell you their pain never leaves. It's there 24 hours a day, 7 days a week. Never goes away. They can't sleep. And they get highly sensitized, and they get autonomic, particularly sympathetic discharge. All those people have high blood pressure, tachycardia, sweating, dilated pupil. These are all people who have too much autonomic discharge, and you can see it on a physical exam. They'll show hormone abnormalities. The family will tell you how dysfunctional these people are. They almost have to have caretakers or family. So these people who fail that ladder, that's a family disease. Somebody's going to have to take care of that patient because they're not capable of themselves, in most cases, of taking care of themselves. Genetic abnormalities, you're starting to hear a lot about this. I'm involved with a study right now in which we're looking at an awful lot of brain receptors, neurotransmitters, and what have you. And everybody's familiar with the cytochrome testing, but this goes way beyond that. And these people are really genetically dysfunctional. They've got all kinds of brain and spinal cord abnormalities, and it's not the subject here today, except I'll just mention that I have personally involved with some studies doing genetic testing in these people, and I'm going to tell you, no wonder they're sick, and no wonder they're hard to manage, because you see receptor abnormalities, neurotransmitter abnormalities, enzyme abnormalities, and that's why you'll see somebody that you'll give them all the fentanyl in the world, it doesn't work. You'll give them all the whatever, and it doesn't work. And so that's mostly genetic. These people have been all over the country trying to get help. Long list of failed therapies. But what I want you to leave here with, the vast majority of these people who failed treatment only have about 4 diagnoses. In other words, there's only a few conditions that you cannot treat with standard treatment. And I want you to leave here knowing these underlying abnormalities and to be able to recognize them and diagnose them. Now, on these treatment failure cases, here's a basic strategy. You want to, first off, identify the underlying cause of the pain. And I'm going to try to list that for you in a few minutes. What you're going to see is the cause. Now, this idea that we're just going to diagnose somebody as low back pain or cervicalgia or neuropathy or neuropathic pain, or fibromyalgia with this, that's nonsense. Those are just vague terms because we don't know what's the matter. But we have the ability today to pretty well pin down the precise diagnosis for these people who really are not doing well with standard treatment. And there's only about 4 or 5 things that cause these people to fail, and you need to be aware of those. And I want to make a point about number 3, opioid malabsorption. It turns out an awful lot of these diseases will cause malabsorption. In other words, if you have any disease of the spinal cord, including the cervical neck, remember the vagus nerve goes right through the neck, right on down to control the stomach and intestine. So you got a cervical neck problem, you may find people who aren't going to respond to Percocet. They're not going to respond to morphine orally. They're not going to respond to some oral drugs because the intestine is a very sensitive organ when it comes to getting some pharmacologic agents into the serum, and it's controlled both by the biome, the enzymes inside the intestine, as well as the nerves that hook onto that intestine. So I hate to tell people this, we've got a whole bunch of people out there that you're going to have to either give drugs to sublingually or by patch, suppository, or injection. And people say, oh my God, they got to take a shot of Dilaudid every day. Oh yeah, there's people who have to do that. And so you've got to know that you've got to be able to recognize a patient who can't get oral opioids or maybe oral anything, even gabapentin, from the stomach and intestine into the serum. So malabsorption is a big issue in pain patients, highly unappreciated. Okay, here are your causes of treatment failure. Most common today is arachnoiditis. Now, that's why this afternoon we're going to have a whole session on it. You can't do clinical practice anymore without knowing about arachnoiditis. Now, almost everybody that we're calling failed back syndrome, if you've got a back pain patient who wants to take opioids, that patient needs a contrast MRI and needs your evaluation to see if they've got lumbar adhesive arachnoiditis. And you also need to start knowing that these terrible neck pain cases, everybody got some? All these old neck fusions and stuff, want to take all the opioids in town? They've got cervical arachnoiditis. And so arachnoiditis is, what it means is an inflammation of the lining or the covering of the spinal cord. It's the covering, the canal. It's the covering of the canal. You got three layers. You got the pia mater, which is just a flimsy little thing to carry nutrients pretty much. Then you've got the middle layer, that's the arachnoid, that carries all the blood vessels and the nerves. Then you've got the dura itself, which is just a kind of a leather covering of the spinal canal. So arachnoiditis, we used to think it was a rare disease. We now know that among those spinal cord patients, it's the most common thing there is. And everybody needs to know how to diagnose it, needs to know what it is, and rather than start using the term low back pain or chronic, sacroiliitis and these vague things, it's time to get a little more scientific and put a diagnosis to it. It's easy to diagnose. Now, genetic causes. This is one that, in the end, I believe 3 years from now, it may well be that Ehlers-Danlos syndrome will be the vein disease in which we're going to have to use high-dose opioids, for example. And the black population, sickle cell disease is with us and will always be with us. But then you've got some other genetic diseases that have caused terrible pain. How many of you here have an Ehlers-Danlos case or even know what it is? Okay, you're ahead of me. I've only recently got myself educated about it. But it's a major problem in pain practice.